everyone. Today we are going to discuss about radial nerve, which is one of the most important nerves in the upper limb in anatomy. So talking about radial nerve, it is a continuation of the posterior cord of the brachial plexus. We have already learned about brachial plexus and the different cords of the brachial plexus, in which we discussed that radial nerve is a branch of the posterior cord. So here we know that it is the continuation of the posterior cord. In fact, it is the largest nerve of the brachial plexus and has the fibers from all the constituting roots of the brachial plexus, which are from C5 to T1. C5, C6, C7, C8 and T1. However, the T1 fibers are not always constant. So while we write an answer about the radial nerve, whether it is a short essay or a long essay, we have to make sure that we write the course of the radial nerve, that is, which are the branches it gives off, which are the muscles it supplies, what are its relation, and which are the different parts. So talking about the course, let's start with from where it is formed. We know that it is formed as a branch of the posterior cord in the axilla. So we know brachial plexus is located in the axilla, right? So in the axilla, the radial nerve, it lies posterior to the third part of the axillary artery and anterior to those muscles which form the posterior wall of the axilla. So which are the muscles which form the posterior wall? We have the subscapularis, the latissimus dorsi and the teres major. So the radial nerve lies anterior to these muscles. And in the axilla, it gives off three branches. The posterior cutaneous nerve of the arm, then two branches to triceps. We have the long head of triceps and nerve to the medial head of triceps. So total three branches are given off in the axilla. Then from the axilla, it enters into the arm at the lower border of the teres major. So this is the teres major and it enters the arm at the lower border of teres major by passing through the lower triangular space. We know there are three intermuscular spaces. Which are those? We have the quadrangular space, the upper triangular and the lower triangular. So the radial nerve along with the profunda brachiae artery enters into the arm at the lower border of teres major through the lower triangular space and lies on the spiral groove or the radial groove, where it is in direct contact with the shaft of the humerus. So here we have a clinical application. What is it? If there is an injury to the shaft of the humerus, there will be injury to the radial nerve in the spiral groove or radial nerve in the radial groove. So while we talk about this, we also need to mention the boundaries of the spiral groove. So where is spiral groove? It is a groove on the humerus. So the anteriorly, we will have the shaft of the humerus, and posteriorly there will be fibers of triceps, the lateral and the long head of triceps. Above the spiral groove, there is lateral head of triceps, and below it is origin of the medial head of triceps. So this is about the spiral groove. So we already discussed all this. And in the spiral groove, the radial nerve gives off 5 branches, 2 sensory and 3 motor. The 2 sensory branches are lower lateral cutaneous nerve of the arm, posterior cutaneous nerve of the forearm. Which are the 2 branches? Lower lateral cutaneous nerve of the arm and posterior cutaneous nerve of the forearm, and then 3 motor branches to 2 muscles. Which are the 2 muscles? Triceps and anconeus. So it gives a branch to the nerve to the lateral head of tricep, to the medial head of tricep, and nerve to anconeus. Then at the lower end of the spiral groove, this radial nerve, it pierces the lateral muscular septum of the arm, and then it enters into the anterior compartment. At the end of the spiral groove, it pierces the lateral muscular septum and enters the anterior compartment. Above the lateral epicondyle, it gives off 3 branches. Nerve to brachialis, nerve to brachioradialis, and nerve to extensor carpi radialis longus. To 3 muscles, brachialis, brachioradialis, and extensor carpi radialis longus. Then what happens is that the radial nerve first descends between the brachialis and brachioradialis, then between brachialis and extensor carpi radialis longus, and then enters into the cubital fossa. At the level of the lateral epicondyle, the radial nerve, it terminates by giving off 2 terminating branches, the superficial branch and the deep branch. Now one point to note that is that the deep branch of the radial nerve is also known as the posterior introitious nerve or the pin, PIN. And the deep branch, which is motor, gives off two branches, one to the extensor carpi radialis brevis and another to the supinator. The superficial branch is a sensory branch. So in the diagram we can see that at the level of lateral epicondyle, the radial nerve is terminating by dividing into two branches, deep and the superficial. The deep branch gives off two branches, extensor carpi radialis brevis and the supinator. Then what happens is that the deep branch, it pierces through the substance of the supinator, which it supplies, and then enters into the posterior compartment of the fora. Pierces through the substance of supinator and enters into the posterior compartment of fora. Here it gives off few branches. It supplies all the extensor muscles of the fora. So whichever extensor muscles are present in the fora, it is supplied by which nerve? The posterior introitious nerve or the deep branch of the radial nerve. Along with that, it gives off two articular branches, one to the distal radioulnar joint and one to the carpal joint. So what happens to the superficial branch? The superficial radial nerve is sensory in function, and around 7 cm above the wrist, it passes posterior to the tendon of brachioradialis. We can see here is a brachioradialis tendon, and the nerve is passing posterior to it, and then it emerges by passing over the tendons of the anatomical snuff box. I am sure that you already know where is the anatomical snuff box. So the superficial branch passes over the tendons of the anatomical snuff box, and then it terminates by giving off cutaneous branches that supplies the dorsal surface of the hand, where it supplies a lateral 3.5 digits but proximal to the nail beds. It does not supply the nail beds. So here it does not supply the nail beds. This is not supplied. This is all by another nerve. It supplies proximal to the nail beds, the lateral 3.5 digits. So this is about the radial nerve. Now let's talk about the clinical application. So while writing an answer about any nerve or artery, we have to make sure that we write a clinical correlation to it. So what is the clinical correlation of the radial nerve? The radial nerve can be injured. Since it's a nerve, it can be injured. So where can the injuries happen? The injuries may be at 3 different sites, either in the axilla, or in the spiral or the radial groove, or at the level of elbow. So any injury in the axilla, mainly caused by crutch palsy. So what is crutch palsy? So in the axilla, the radial nerve, it can be injured by excess pressure of the upper end of the crutch. So this is known as crutch palsy. So there can be motor loss and sensory loss. First, let's talk about the motor loss. So we know from the axilla, the radial nerve is giving off lot of branches which supplies lot of muscles. So if there is a paralysis of triceps, which will definitely happen, because of it there can be loss of extension of the elbows. So paralysis of the triceps due to this injury at the level of axilla can cause loss of extension of elbows. And then due to the paralysis of the wrist extensors, okay, there can be loss of extension of the wrist. So what will happen? There will be wrist drop. This is the image of wrist drop. This happens because there is unopposed action of the flexor muscles of the fora. The extensor muscles are not functioning, whereas the flexor muscles are functioning unopposed. So there will be wrist drop. Then there can be loss of extension of the digits due to the paralysis of extensor digitorum, extensor indicis, extensor digiti minimi, and extensor pollicis longus. So because of that, there will be loss of extension of the wrist and there will be loss of extension of the digits. Then there will be loss of supination in the extended elbow because the supinator and the brachioradialis both are paralyzed. But supination becomes possible in flexed elbow. Why? Because there is the action of the biceps brachii. Is the biceps brachii supplied by the radial nerve? No. So even if there is injury of the radial nerve, supination is possible in the flexed elbow due to the action of biceps brachii. Then there will be sensory loss. Sensory loss occurs on a small area of skin over the posterior surface of the lower part of the arm, and then sensory loss along a narrow strip at the back of the forearm, and then the sensory loss on the lateral part of the dorsum of the hand at the base of the thumb, here base of the thumb, which is an isolated sensory loss, and dorsal surface of lateral 3.5 digits, which is supplied by the superficial branch of radial nerve. Next, the radial nerve can be injured in the radial groove. So the injury in the radial groove can be caused either due to the midshaft fracture of humerus or a wrongly placed intermuscular injection or IM injection, or it can be due to direct pressure on the radial nerve by a drunkard who falls asleep with his one arm over the back of the chair, as we can see in this diagram. So what happens? There will be excess pressure there in the radial groove. So this is also known as the Saturday night paralysis or Saturday night palsy. So the injury to the radial nerve occurs most commonly in the distal part of the groove beyond the origin of the nerve to triceps and the cutaneous nerve. So the clinical features which are observed in this case, the motor loss includes the loss of extension of the wrist and the fingers. There will be wrist drop. There will be loss of supination when the arm is extended, and the sensory loss is restricted only to a very small area over the dorsum of the hand between the first and the second metacarpals. Just a small area is affected. Extension of the elbow is possible, but it may be a little weak because the nerve to the long and the lateral head of triceps arises in the axilla, which is before the site of lesion. That is, it is before the radial nerve supplies the triceps. These nerves, that is, these branches are arising from the axilla, and this axilla is located above the radial groove, right? So even if there is an injury to the radial groove, these branches will not be affected. And the third part is the injury to the radial nerve at the level of elbow. This is known as a radial tunnel syndrome. Radial tunnel syndrome. Where have you heard a similar term? We have heard about the carpal tunnel syndrome. So these tunnel syndromes, the radial tunnel syndrome, carpal tunnel syndrome, they are all entrapment neuropathies. So here, the radial tunnel syndrome is an entrapment neuropathy of the deep branch of the radial nerve that occurs at the level of elbow. It can be caused due to several reasons, like the fibrous bands which can tether to the radial nerve. It can tether the radial nerve to the radiohumeral joint, or it can be caused with sharp tendinous margin of the extensor carpi radialis brevis, or the leash of vessels on the radial recurrent artery, or it can be caused due to the arcade of Frost, which is a fibro-aponeurotic proximal edge of the superficial part of the supinator muscle. The supinator muscle, the superficial part, the proximal edge of the superficial part is a fibro-aponeurotic portion which forms the arcade of Frost. The characteristic clinical features observed in this case includes the loss of extension of the wrist and the fingers. However, they will not be wrist drop. Then there will be pain over the extensor aspect of the forearm. So these are the clinical features observed in case of injury to radial nerve at the level of elbow. Now let's have a quick run through about the course of the radial nerve and how to draw a diagram of the radial nerve if it comes for exam. So first you have to mention all the routes from which it arises from C5 to T1, which forms the radial nerve. Then this is the axilla. So in the axilla it gives rise to the posterior cutaneous nerve of the arm, which is a sensory branch, and then two motor branches, one to long head of triceps and the other to the medial head of triceps. Then it passes down into the arm, the lower border of teres major, where it lies in association with the profunda brachiae artery. This is the profunda brachiae artery, and then it supplies the lateral head of triceps, and then gives off the lateral cutaneous nerve of the arm, the posterior cutaneous nerve of the forearm, and supplies the anconeus too. Then it pierces the lateral intermuscular septum and then supplies the brachialis, brachioradialis, and extensor carpi radialis longus. Also gives a articular branch to the elbow joint. Then what happens is that it enters into the forearm, where it terminates at the level of the lateral epicondyle into the superficial and the posterior interosseous nerve. Superficial radial nerve, we'll discuss about it later. First, let's talk about the posterior introitious nerve, the deep branch. It supplies the supinator, which it pierces, and then it supplies the extensor radialis, extensor. This is extensor carpa radialis teres. The extensor carpa radialis brevis. Then it supplies the extensor digitorum, the extensor digiti minimi, the extensor carpi ulnaris, the abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, the extensor indicis, and then it gives a branch, articular branch, the inferior radioulnar joint and the wrist joint. All the extensor muscles of the forearm. Now let's talk about the superficial branch. The superficial branch found in relation to the radial artery. It passes down, then over the in relation to the tendons of the brachioradialis, the abductor pollicis longus, the extensor pollicis brevis and extensor pollicis longus, and then terminates by giving cutaneous branches to the skin of the lateral side of the dorsum of the hand and the lateral 3.5 digits except the tail bits. So this is about the radial nerve.